Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Brad Kahl from Washington University in St. Louis and Dr. Anthony Mato from the Memorial Sloan Kettering Cancer Center. They will be discussing their choices of 3 recent notable studies presented at ASCO 2022 on the use of BTK inhibitors in mantle cell lymphoma and CLL and the associated potential clinical implications. This episode is part of a larger educational program titled A Global Perspective on Emerging BTK Inhibitor Therapy Data for Relapsed Refractory CLL and MCL in 2022. For more information on the experts, along with a link to the complete program, including a downloadable slide set and expert commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
So hi everybody, I'm Brad Kahl from Washington University in St. Louis.
Hi everybody, my name is Anthony Mato from Memorial Sloan Kettering Cancer Center. We're here today to discuss some of the interesting data that have been presented this spring at the American Society of Clinical Oncology meeting. Brad and I both take care of patients with CLL and lymphomas. Brad is an internationally famous lymphoma physician, and so great opportunity to hear his thoughts on some of the data presented in mantle cell lymphoma. So Brad, I'm not caring for a lot of mantle cell patients at the moment, but of course at ASCO, the buzz was about Michael Wang's presentation called the SHINE study. So I was wondering if you could give me an update and give the audience an update about this trial, what it means, will it change practice, and the implications for future trial design.
You bet. Happy to walk through this one, Anthony. So SHINE was a really interesting presentation, and it's one of those trials where I don't think the results are really black and white, and I think reasonable people could differ on how this impacts practice, and I'll try to talk through what I mean by that. So this was a trial for frontline mantle cell lymphoma. It was designed for older patients. They needed to be 65 years of age or older with advanced stage disease and in need of treatment. And the control arm for the study was something that is very commonly utilized in older mantle cell. It's bendamustine rituximab for 6 cycles, followed by 2 years of maintenance rituximab. And that's a very commonly used strategy in the United States and all over the world, frankly. And the experimental arm in this trial was exactly what I just described for the control arm, with the addition of ibrutinib, the BTK inhibitor, given at the typical mantle cell dose of 560 milligrams orally daily. And the patients would take the ibrutinib throughout the BR induction for those 6 cycles, as well as during the 2 years of maintenance rituximab, and then continue the ibrutinib past the end of the rituximab until disease progression or unacceptable toxicity. So really indefinite ibrutinib during the treatment duration. Obviously, ibrutinib is a first-generation BTK inhibitor. It's been approved for many years in relapsed mantle cell lymphoma. And this was really the first effort to bring it to the frontline setting. Now, the primary endpoint of this study is progression-free survival. So the trial is completely enrolled, and this was the first time we were able to see the data. There were about 260 patients in each arm, or a little over 500 in total. The median age in each arm is 71, so it truly is an older mantle cell patient population, and the patients were well balanced for baseline features like MIPI risk score and performance status and stage and P53 mutation. So the randomization worked, and there were no problems with the treatment assignment. If one gets to really the top line result, what did we learn? So it turns out that the progression-free survival was improved in the ibrutinib arm. And just to put some numbers around this, the median progression-free survival for ibrutinib BR was 80 months, and the median progression-free survival for placebo BR was 52 months. So there was a 2.3-year difference in the median progression-free survival. So that's a pretty large benefit in median PFS. It's very interesting if you look at these curves visually, which I know people can't do on a podcast, but this paper is now published in New England Journal of Medicine, and I think it's worth taking a look. The curve separation, the amount of difference between the two curves, I would say is relatively modest. So if you look at different landmarks like 3 years and 4 years and 5 years of follow-up, there's about a 10% difference between the two curves in the progression-free survival. And at 5 years, the control arm is right around 50% of the patients are still in remission. And the experimental arm at 5 years is about 60% of the patients are still in remission. So if you look at it that way by landmarks instead of median, the difference isn't quite as pronounced. And so I think it's just worth thinking it through both ways. When you look at the different subgroups, the benefit for ibrutinib was pretty uniform, whether you're looking at male versus female or age over 70 versus less than 70 or MIPI risk and things like that, tumor bulk, the differences were pretty uniform. Now, was there a difference in the overall survival between the two arms? There was not. The overall survival is equivalent. And so we have one of those situations where you add a treatment and you get a progression-free survival benefit without an overall survival benefit. And then that begs the question, is it worth it? So to answer that question, one really needs to look at toxicity. There's definitely a bit more toxicity in the ibrutinib-containing arm, a bit more risk for bleeding, a bit more risk for atrial fibrillation, hypertension, arthralgias, some increased risk for infection. What's really interesting if you start looking at things numerically, so death due to progression was more likely in the patients who didn't get ibrutinib, but death due to treatment adverse events was more likely in the patients who did get ibrutinib. And so ibrutinib definitely helped control the disease better, but that was partially offset by some increase in toxicities and even treatment-related adverse events that could be attributed to cause of death, including infections, cardiac disorders, etc. So the overall survival ended up being essentially a tie. And so it really begs the question, is this practice changing? And I think that's really in the eye of the beholder. It's definitely practice influencing. And I could see some people moving in the direction where they're going to incorporate ibrutinib into the front line if this does get an approval, which I assume it will based upon these data. And so it would be a nice option to have. But it's one of those situations where because there's no overall survival benefit and because the progression-free survival benefit does come at some toxicity cost, and because you are now using up your BTK inhibitor in first line, which means you may not have it available for second or subsequent lines, not everyone may migrate to this new regimen. And some investigators, including myself, I think, may prefer to continue to hold the BTK inhibitor for the relapsed setting. So with that, Anthony, I'll pause and just see if that made sense and see if you have any questions for what I just covered.
That made a lot of sense to me. This reminds me a little bit of the Helios trial in CLL, which was BR plus or minus ibrutinib versus placebo. After the trial was conducted, which was a positive trial, the same findings, PFS but not OS, people went back and superimposed the BR curve over, this is relapse refractory, the BR ibrutinib curve over the ibrutinib monotherapy from other trials. I'm just wondering, is your gut feeling that like 95% of the work here is being done by the ibrutinib, and that had they had an ibrutinib monotherapy or an ibrutinib rituximab arm, that we would have seen the same result without having to expose patients to chemotherapy?
That's a great question. And my best guess here is that ibrutinib is not doing 95% of the work. And I say that because the control arm performed extremely well here, with 50% of these frontline mantle cell patients still in their first remission at 5 years. So it turns out BR with our maintenance is a very good platform for older mantle cell lymphoma. Having said that, we don't really know how well ibrutinib alone would perform 5 years out, or ibrutinib plus rituximab alone would perform 5 years out in this exact identical patient population. There was a recent publication in JCO looking at low-risk mantle cell patients, and their ibrutinib by itself performed very well in the front line, but that was a more favorable patient population. There is an ongoing international study called Mangrove, which is testing zanubrutinib plus rituximab against BR. So we will get the answer to the question you just posed, but that's several years away. But the short answer is I don't know if ibrutinib alone, I don't know what that would get you frontline in an unselected patient population. It will probably get you a very good result, and maybe you don't need the BR. We just don't know that yet.
Got it. Oh, that's super. That is really helpful. I'll be curious to hear more in the future if the standard of care is changed as a result of this approach.
Yeah, like I said, I think this is one of those where reasonable people might differ a bit about the interpretation and how they incorporate these results into their own practice. It's going to be like using rituximab maintenance in follicular lymphoma. Either way is fine. You can give it or you can choose not to give it. There's pros and there's cons to it. So with that, I'll stop talking about SHINE, Anthony, and let's shift gears to CLL, because at the meeting we saw some updated data from the CAPTIVATE study, which is a really interesting, I think, creatively designed study that we've seen some updates on in CLL, and we got a 3-year update on the fixed duration cohort. So what can you tell us about CAPTIVATE?
Sure. CAPTIVATE is a trial looking at this new fixed duration combination that we call I plus V, ibrutinib, the BTK inhibitor, in combination with venetoclax. And it's a little bit of a complicated trial design, and I won't talk about it today, but there's an MRD-driven arm, which probably won't become the standard of care. But there's also a fixed duration arm where patients get 3 months of ibrutinib as a monotherapy, followed by a 12-month overlap with the combination of ibrutinib plus venetoclax, and then everybody stops. And as you know, there's this big trend in CLL now to move away from continuous therapies more towards fixed duration schedules, because patients want to stop therapy. Ultimately, there's potential cost savings, and the mechanisms of resistance may be markedly different if we're doing sort of these intermittent treatment schedules or these treatment holidays with long remission durations in between. So the data for CAPTIVATE have been presented a few times in the past, but what we now have is a little bit longer term follow-up, and particularly a window into patients with high-risk disease, which I think is really important. The number of patients who participated in the fixed duration schedule was 159 patients, so a relatively large number of patients, relatively high-risk population. So there was 17% with a deletion 17p or a TP53 mutation, probably higher than we see in a completely unselected frontline patient population. The median age was young, and that's really important to note because I could tie in other trials like GLOW and CLL13 here. But this is a young population. Median age is 60. The oldest patient on the study was 71, which is the average age for diagnosis of CLL. So this is really a window into how a I plus V fixed duration schedule performs in a young patient population with some poor risk features. The other thing I'll add here is, before I provide the data, is that this is a non-randomized trial. So I won't be able to give you a comparison of I plus V versus I or versus VO or versus some other clinically relevant control. All we're going to have is this data set to stand by itself in the young population. The GLOW trial uses the exact same regimen in an older, less fit patient population. But of course, there the comparison is to chlorambucil-based therapy. They get chlorambucil and obinutuzumab, which many would argue is not a relevant control, given that ibrutinib with obinutuzumab has already beaten that control, and venetoclax with obinutuzumab has already beaten that control. So the contribution of components would suggest that either one of those drugs would be better than the control to begin with. So a less relevant comparison than many of us would like to have seen. The I plus V regimen was effective. Response rates were way over 90% for patients with the deletion 17p, or those who were unmutated, or across the board, nearly 100%, essentially a 95% overall response rate. The other thing that's interesting here is that we have some comparison to the original trial led by at MD Anderson by Nitin Jain in terms of MRD. And I think most people in the field think that achieving undetectable residual disease, either in the peripheral blood or the bone marrow, is the window towards developing a time-limited therapy. And what's interesting here is that the MRD rates, at a sensitivity of 10 to the minus fourth, were less impressive than we would have expected from regimens like venetoclax and obinutuzumab, the CLL14 regimen. And just to give you an idea, the 3-month post-treatment rate of MRD at 10 to the minus fourth was 57%, kind of underwhelming. And then 12 months after the completion of therapy, 43% of patients remain undetectable. So it didn't induce as deep a remission as I would have predicted. But with that being said, the remissions were durable. And at the 3-year update, the median progression-free survival was not reached for any population. However, what we have seen is that there have been some progression events in the del-17p patients in particular. There are progression events across the board, but more in the del-17p population than we would have expected. And the hope for the fixed duration schedule with a ibrutinib-containing regimen was that that would address the limitation of what many perceive to be venetoclax obinutuzumab, in that the ven-obin is not great maybe for the del-17ps as per CLL14. But I think the lesson we're learning here is maybe these poor risk patients need continuous therapy regardless of what you pick, because we're starting to see progression events here. So it's not going to be as good in that patient population. And then, of course, the overall survival across the groups was the same. So excellent overall survival, very few deaths on the trial. The other thing that came out of this is retreatment. So you're getting 15 months worth of therapy, you stop. What do you do later when they progress? Are they sensitive to other therapies? And that's really, really important question. And what we have from this data set is that patients could be retreated with ibrutinib upon progression. Ibrutinib is a monotherapy, continuous therapy. And nearly every patient, small number now, who were evaluable for response, did respond to ibrutinib. There were 12 patients evaluable for response. 9 of those 12 patients had a PR, 1 had a PRL, and 1 had stable disease. So ibrutinib works again in this population, which is very relevant. So the summary here was that it was safe and effective. The question that I have is, how will this change the standard of care in young fit patients versus older patients? Because when you look at the data from a couple of other studies that I'll just mention now, the GLOW trial and the CLL13, which doesn't include an I plus V arm, but does include an I plus V plus O arm, it does seem like the AEs in older, less fit patients, particularly from GLOW, are more than we would see with, for example, venetoclax obinutuzumab. So there's just some questions now about how the standard of care will be influenced. It's going to be an important tool, and I'm looking forward to seeing further updates in the future. So I'll leave it there, and I'm curious if you have any questions or thoughts about this regimen.
Yeah, I do. So obviously these time-limited novel combinations are something everyone is keeping an eye on. We have V plus O approval, obviously, but we don't have I plus V approval. But are you expecting us to get an ibrutinib plus venetoclax approval in the next year or so based upon GLOW results, maybe supported by CAPTIVATE?
I think so. This is what I'm hearing from others. I actually don't know the timelines in terms of their regulatory pathway, but I think within a year, that's what I've heard from others. So we'll have to see, what the FDA thinks, of course.
Yeah. And if GLOW is the primary source of the approval might be limited to older patients, although sometimes with BTK inhibitors, the agencies have extrapolated the data into younger patients. Do you have any sense of what to expect there?
I actually don't. I suspect it'll be a broad label because most of the targeted therapies, regardless of the population they've been studied in, haven't been really pigeonholed into an older population or a less fit population. But with that being said, I'm really not sure. So I'll be very curious to know that answer myself.
Yeah. So let's try to imagine a world where you do have, this doublet approved, ibrutinib plus venetoclax, sort of an embarrassment of riches. We already have a pretty good menu in frontline CLL with venetoclax obinutuzumab, or you can give BTK inhibitor plus obinutuzumab, or you can give single agent BTK inhibitor. And then, of course, the patients come in different flavors. Some are mutated and very favorable. Some are unmutated. Some have high-risk features like 17p. So let me walk you through 3 patient scenarios, and you can help us think through the menu and what might make the most sense. So let's say you have a patient come through the door next year. You have all these options, and it's a 70-year-old who has mutated disease, everything's favorable, but they need treatment. What therapy will look most attractive to you for that patient?
You said IGHV mutated?
Yes.
Well, that's a good question because I think there is no one therapy that will be most attractive. The ven-oben performs exceedingly well, as do any BTK inhibitor-based therapy. So they're based on efficacy data. I don't think that there's a compelling argument that you have to do one approach or the other. I think some people are starting to think about the other situation, the unmutated patients or the del17p patients, and whether or not there's more data accumulated now to support continuous BTK inhibitor-based therapies. The ven-oben curves separate in CLL14 based on IGHV status. But honestly, I think that as long as you're not providing chemotherapy to these patients, it's an open-ended question, and we really need relevant comparator trials in high-risk patients in order to address that question accurately.
Yeah, we really are lacking comparative data. So if you had a very high-risk patient right now, 17p deleted, you would lean toward indefinite BTK-based therapy?
Slightly, but I also think, ven-oben, the median PFS in 17p patients is 49 months, not too bad. And then there's emerging data about retreatment to suggest that it works well again in this situation. So assuming it works about half as well, you're looking at like a median PFS of about 75 months. This is excellent and very comparable to what one would expect from a PFS2 perspective as compared to what you would get out of ibrutinib or acalabrutinib or acala-oben in the frontline setting. But I still think it's mostly a wash, but I would love to see the comparisons done.
Right. And for the very common scenario of an unmutated patient who needs therapy, again, you have all these options. Are you favoring time-limited therapy for those patients right now or indefinite therapy, or is it a coin flip?
I still think it's a coin flip. I don't have strong opinions except to say that chemoimmunotherapy should just be off the table for those patients. But I present both options to patients, look at their comorbidities and their preferences, and then make decisions based on that.
Sort of involve the patient in the decision-making?
Yeah, for sure.
Yeah. Okay, sounds great. So let's go to the next abstract that we wanted to discuss, which is a phase 1/2 trial of zilovertamab, which is an anti-ROR1 antibody. And this is a trial combining this novel monoclonal antibody with ibrutinib in mantle cell or CLL. So what can you tell us about this abstract?
Yeah, so the concept is new to me. This is an anti-ROR1 antibody that's being studied in this particular population. Very broad study in that they're looking at both CLL and MCL, and patients were included in this trial, I believe, who were treatment naive and relapse refractory. So a very broad patient population. Obviously, the main point of such a study was to gather safety information. But additionally, we want to understand whether or not there's any advantage to these novel combinations over the targeted therapy by itself. The other thing that's interesting here is that finally we're breaking away from CD20 being the partner antibody, because I think you and I both would agree that in lymphoma and CLL, we exhaust that target to death in several lines of therapy. It's nice to have another cell surface marker to target. And ROR1 is one that's expressed or overexpressed across B-cell malignancies, but particularly there's an interest in patients with CLL. There are 3 parts to the trial that I'll mention as well. The dose-finding cohort, the dose expansion cohort, and then the randomized cohort. And I'm trying to remember how the randomization took place. Do you remember from this trial, Brad?
I think it's a 2-to-1 randomization favoring the zilovertamab ibrutinib.
Yeah, and so the data that we had at the time of the presentation was for part 1 and part 2, 33 patients with MCL, 34 patients with CLL, and then for the part 3, 18 patients with CLL got the combo and 10 patients got the monotherapy. So tiny numbers. Even the largest data set here is like only 30 plus patients. We got a window into the adverse event profile for this combination in both MCL or CLL for part 1 and part 2. And it looks like a relatively well-tolerated combination to me. Hard to judge, but it looks like there's nothing more here than I would have expected from the perspective of BTK-specific toxicities and or antibody-mediated toxicities that I would have expected from either drug alone. although not completely easy for me to judge because unlike the SHINE or the CAPTIVATE, where I've used those drugs before, I never used this drug before. So it's sometimes reading an AE table can be a little bit misleading, but there were not a lot of grade 3, 4 events in either disease. And that's probably the most relevant thing. I don't know. Did you have that? Did you walk away with the same feeling from this?
I walked away with the same feeling. It looked a lot like a toxicity table you might expect from ibrutinib alone.
Yeah, so that's a good sign. And then in terms of the overall response rate, they presented the MCL and the CLL efficacy data separately. So overall for MCL, the response rate was 85%. The CR rate was 40.7%. They also looked across subgroups like, high key 67 with 35.7% CR rate. Prior ibrutinib, a very small number there, was a 40% CR rate with an overall response rate of 80.8%. They looked at prior CAR T, tiny number of patients, but there were responders, bulky disease, and P53 mutation. Across the board, the response rate appeared to be consistent. And my kind of gut take on it was that there was a higher than expected rate of CRs than one would see with ibrutinib alone for mantle cell. Would you agree with that?
I would agree with that. Obviously, the numbers are small, but we don't expect CR rates of 40% with single agent ibrutinib. So there is an early sign that the monoclonal antibody is contributing to efficacy.
In the CLL, I think the results were a little bit more controversial. The response rates were high across the board, and they looked, overall, no prior treatment, 1, 2, 3, 4 prior treatments. They also looked at some other risk groups, and the response rates were lowest was 70% in patients who had 2 prior therapies, but the CR rates were relatively low and consistent with ibrutinib by itself, or maybe a little bit higher than one would expect with ibrutinib by itself, but it wasn't overwhelmingly different than I would have expected with ibrutinib alone. Now, whether this is a window into a time-limited therapy with ibrutinib or in CLL or MCL, I don't know. Does this look any different than ibrutinib plus a CD20, particularly in the earlier lines of therapy? I don't really think so. So my general take on this, and this is with a tremendous amount of lack of knowledge, never using the drug, not being super familiar with the ROR1 as a target, in terms of small molecule inhibitors, antibodies, CAR T, or antibodies tagged with chemotherapy, was that it looks to be more important in mantle cell than it does in CLL. And of course, having randomized data that, with a clinically meaningful endpoint in either disease or in CLL in particular would be relevant. So I walked away thinking might have a future in mantle cell, not clear yet in CLL, but toxicities should not limit the drug itself.
Gotcha. Thank you for that. Yes, very interesting early data for this monoclonal antibody. I think you're right. It's going to take some trials with control arms to really sort out the contribution. It's early days, and this is just an agent that we'll need to keep our eye on as we go forward. Just thinking ahead, Anthony, I know you've been heavily involved in the development of a third-generation BTK inhibitor, pirtobrutinib. I'm now getting some experience with that myself, participating in some of the ongoing trials at mantle cell. Tell me what you think about pirtobrutinib and its potential in these diseases.
Oh, I think the potential is really, really great. The most important aspect of the Bruin study is the population. And I can speak to the CLL population. More than 250 patients previously treated with a covalent inhibitor, 40% previously treated with venetoclax, 20% had a PI3K. So this is like the population where there is really no great standard of care. The survival data that's been published, albeit limited, is poor. And yet the response rate is nearly 70% in CLL. For the 252 patients who previously had a covalent BTK inhibitor, the median PFS is not reached. And the AE profile looks spectacular, 1% discontinuation rate due to side effect. So it seems like the perfect storm of activity in a relevant population with minimal AEs for patients, which is a great building block for combination therapy. So I do think it has a great future in CLL. I've seen Michael Wang present the data in mantle cell, not as durable a remission, but pretty spectacular for the prior covalent BTK inhibitor population, who there really are not great options for. I've seen data for lenalidomide in this situation, looks pretty poor. So I think it does have a future in both diseases. And of course, the trajectory to earlier lines of therapy will be determined based on the randomized trials that are undergoing right now.
Great. Well, Anthony, I always enjoy talking to you, and I learn a lot every time I do. Do you have any data sets coming that you see coming in the future that will be really important in the management of CLL?
I'm trying to think about the peer-to randomized trials I think are really important, but I don't expect those to be presented in the near future. There's several exciting frontline trials that are just getting underway or enrolling pretty heavily right now. The CLL 17, I think, will be really important. This is ibrutinib versus I plus V versus V plus O. Matt Davids, Jeff Sharman, and I are partnering on a trial called the MAGIC trial, which is going to look at A plus V versus V plus O in the front line. I think these trials stand out to me because both are using VO essentially, or I, in the case of CLL 17, as a relevant comparator. So it's, modern therapy versus modern therapy, fixed duration versus continuous, MRD driven in the case of the MAGIC study versus MRD driven doublet. So I think we will have some relevant comparisons that will aid significantly in how we choose patients for poor risk disease. What's lacking, I think, is the high risk population being studied exclusively in clinical trials. But there's lots of classes that I'm excited about. I want to hear more updates about the bispecifics. I want to hear about BTK degraders, two classes that I think are exciting. And then, of course, CAR-T has been lagging behind in CLL now for years versus what's been done in lymphoma. And many people are starting to think that the time for CAR-T to be available to CLL patients may be soon and or studied in earlier lines of therapy. So lots coming in CLL in the near future.
Yeah, lots to look forward to. All right, Anthony, I enjoyed it. Good talking to you today.
Thank you very much, Dr. Kahl and Dr. Mato, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, a global perspective on emerging BTK inhibitor therapy data for relapsed refractory CLL and MCL in 2022, and to access additional resources associated with this program from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.